Next, in mental status examination, heading number 5 is cognitive functions. Cognitive function means higher mental functions. Higher mental functions. Okay. Higher mental functions include number 1, consciousness and orientation. When we present a CNS case in MBBS final viva, we present like this: on CNS examination, higher function normal, or we say patient is conscious, cooperative, alert, well oriented to time, place, person. Because consciousness is the first higher function. Consciousness means awareness of self and environment. And orientation is always tested in 3 parameters: time, place, person, in which time is first to be lost. Why do we say time, place, person? Because when the person becomes disoriented, time is always first to be lost. There are different examples of impaired consciousness which are asked in our exam. First, a very frequently asked terminology is stupor. Stupor is defined as a condition of akinesia where the person does not move plus mutism. Akinesia plus mutism. Can't move, can't speak, but he is awake and alert. Unlike coma, where he is completely losing consciousness. Stupor can be organic stupor with a cause. Stupor can be psychogenic stupor. Psychogenic example: anxiety states, dissociative stupor, conversion disorder stupor. We shall discuss dissociation and conversion. Organic example: head injury causing stupor. Stupor is akinesia plus mutism in awake alert patient. Akinesia means can't move. Mutism means can't speak but awake and alert. Akinesia means can't move. Mutism means can't speak but awake and alert. Okay. On benzodiazepine or barbiturate, this stupor improves and this stupor worsens. Because benzodiazepine decrease anxiety, so it improves this stupor. But benzodiazepine further lower the sensorium in head injury, so worsens the stupor. This is how we differentiate organic versus psychogenic stupor. On benzodiazepine or barbiturate, this stupor improves and this stupor worsens. Because head injury related stupor is related to lowering of sensorium. Got it? Stupor was asked in AIIMS exams. Second of impaired consciousness is twilight stage. Twilight is defined as abrupt onset and variable duration interruption in the continuity of consciousness. It is again seen in head injury, epilepsy, etc. The person is normal conscious for some time, then loss of conscious, then again normal conscious, then again loss of conscious, then again abnormal conscious. So in between the consciousness gets interrupted. That is called twilight. Normal conscious, then normal conscious, then normal conscious. In between abnormal conscious. Islands of abnormal consciousness in between periods of normal consciousness. Third comes oniroid. Oneirology is the study of dream. The term oniroid comes from waking dream-like state. In which the person is disoriented, he also has visual hallucination. This condition may be seen in schizophrenia patients, known as onirophrenia. This was asked in INI-CET exam. So these are the three examples of impaired consciousness: stupor, twilight, and oniroid. Got it? Then comes the second higher function, attention and concentration. Sustained attention is called concentration. Sustained attention is called concentration. How do we test it? Serial, hundred minus 7 subtraction test. Serial 100 minus 7 subtraction test. We ask our patient 100 minus 7. He will say 93. Then we tell him keep on subtracting 7s and give me the next 5 results. So he will tell me 86, 79, 72, 65 and 58. Second test is digit span test. This was asked in AIIMS exam. Also known as digit repetition test. It is of two types, digit forward and digit backward. We give our patient at a rate of 1 digit per second and we stop after 2 failures. We tell our patient to repeat at a rate of 1 digit per second and we stop after 2 failures. Example, if I tell him to repeat 1, 4, 3, he's supposed to repeat 1, 4, 3. 1, 9, 4, 7, he will repeat 1, 9, 4, 7. 2, 3, 9, 6, 4. He will repeat 2, 3, 9, 6, 4. 1, 8, 3, 6, 2, 4, 1. He will repeat like this. Normal person can repeat up to 7 digit forward. And in digit backward, if I say 392, he is supposed to say 293. 1836, he is supposed to say 6381. 1C6384, he is supposed to say 48361. Digit backward, normal people can do up to 5 steps. And in this, skips are not allowed. The question asked in AIIMS was, all are true about digit span test. Digit forward normal up to 7, digit backward normal up to 5. Skips are allowed, skips are not allowed. This is the second cognitive function, attention and concentration. The first cognitive function was consciousness and orientation. The second cognitive function is attention and concentration. Let's move on to the third cognitive function. Memory. There are three types of memory. Immediate recall, recent memory, and remote memory. Immediate memory is within seconds to minutes. Recent memory is minutes to hours to days, and remote memory is days to months to year. If you see that carefully, don't you see that it is overlapping? Because ultimately immediate only forms recent and recent only forms remote. Immediate memory is directly proportional to attention. That's why to test immediate memory, we have to do attention test. To test remote memory, we have to do last 24 hours recall test. What did you have in dinner last night? What did you have in breakfast yesterday morning? And to test remote memory, we need to ask past events of life. Past events of life, like when did you pass class 10, when did you pass class 12. When the person loses recent memory, we call it anterograde amnesia. When the person loses remote memory, we call it as retrograde amnesia. Anterograde amnesia is more commonly seen in head injury. And retrograde amnesia is more commonly seen in dementia patient. Loss of recent memory is known as anterograde amnesia, and loss of remote memory is known as retrograde amnesia. Anterograde amnesia has got one more definition. Inability to form new memories. Done? Okay. Then Remote memory is further classified into implicit or procedural and explicit or declarative. Implicit is that memory which does not require conscious attention to recall, and explicit is that memory which requires conscious attention to recall. Those things, recalling of which requires you to focus towards the question, is called implicit. Does not require you to focus toward the question. Example, it includes all your skills, habits, and procedures. Cooking, driving, sewing, etc. Let's talk about one of the most basic skill which many of you have, I suppose, driving. Most of you know driving, maybe two-wheeler, maybe four-wheeler, maybe rickshaw, whatever you prefer. When the first time you learned driving, somebody must have told you like this is clutch, this is brake, this is gear, this is accelerator, this is how you change the gear. And many of us were so conscious while driving for the first time, we were telling the other person sitting next to us, you sit quietly, otherwise I may forget the step of driving. But now you have done driving so many times in your life, do you think you need to focus on the car for driving? No. You can drive without even paying attention toward the car. Same goes for cooking. Your mother cooked a new dish looking at the recipe book. She looked, she cooked. She looked, she cooked. Now she has cooked the same dish 100 times. Do you think she needs to look into the book again? No. Sewing, embroidery, all those skills which you have acquired by doing it is implicit. It does not require your focus toward the question. And anything that requires your focus is called explicit. Okay? Explicit further includes all your facts, and all your events. Rules, words, language. Rules, words, language is semantic memory. This question came in Ames. The question was straightforward. Semantic memory includes all except rules, words, language, and the answer was events. Your own life events come under episodic memory. That's all about the third cognitive function, memory. Coming to the fourth cognitive function, abstract ability. Abstract ability means understanding in depth the hidden meaning of the concept. Understanding in depth means abstract ability. Loss of abstract ability means concretization of thinking. Concretization means superficial thinking. How do we test abstract ability? Number one, proverb test. Number two, similarity test. Asking the person to interpret a story. Abstract ability means understanding in depth the hidden meaning or the concept. Loss of abstract ability means concretization of thinking. Concretization of thinking. How do we test it? Number one, proverb test. Have you heard of a proverb? We ask the patient a proverb. If the patient gives in-depth meaning, he has good abstract ability. If he only gives little superficial meaning, he has poor abstract ability. That is concretization of thinking. I asked my patient, you must not hit your own foot on an axe. He said, yes sir, we must not hit our own foot on an axe. It will cause bleeding. The meaning is you must not cause loss to yourself. So if you give an abstract meaning, in-depth meaning, that means you have good abstract ability. If you give little meaning, you have concrete. Let's try. All that glitters may not be gold. The meaning is everything that looks beautiful may not be good. You must not go by the external appearances. Don't judge a book by its cover. Patient said, yes sir, all that glitters may not be gold. My teeth glitter, they are not made of gold, they are yellow. Patient answer is concrete. So if the person gives in-depth explanation, abstract, superficial, concrete. Similarly, if I ask him similarities, if he gives structural similarity between two things, he is concrete. If we give functional similarity, he is abstract. I asked him what is the similarity between table and chair. He replied both are four legs. Concrete. Both are furniture. Abstract. What is the similarity between apple and orange? Both are fruits. Abstract. Both are round. Concrete. Got it? Third test. asking the person to interpret a story. This test came in All India 2016. This test has not been done by me on any patient because it's very time consuming. But after it came in the exam, I realized this test was done on me by my school teacher. In my school, I had a subject called moral science, in which my teacher asked a story. The most famous story of my childhood has been A Thirsty Crow. Once there was a crow, it was very thirsty, it flew everywhere for water, it couldn't find water. In the end, what the crow did? Throw stone, water came up and the crow drank it. And what did they ask? Moral of the story. Where there's a will, there's a way. So if you can tell moral, abstract. And some students were very straightforward. Man, what moral? Throw stone, water up, physics. That is concrete. Fifth and last but not the least, cognitive function. Reasoning and judgment. In this, we give our patient an arbitrary test situation. What will you do if you find an address letter on the roadside? What will you do if you find an address letter on the roadside? What is normal people answer? In this, the normal people and the diseased people answer will differ. Normal people will say, I shall post it. The diseased people will give different answer depending on the disease they have. Schizophrenia will say, I will not touch the letter, sir. It has been sent by my enemies. Because he is paranoid, so he will take letter also as a part of his paranoia. Depression patient will say, I will not touch the letter, sir, because what's the fun in touching the letter, sir? If I touch, I will die. If I don't touch, I will die. If I read, I will die. If I don't read, I will die. So why read and die? Better not read and die. Mania, I will definitely read the letter, sir. Love letter, sir. Love letter. So depending on the patient's clinical condition, the answer will differ. Got it? Please write down cognitive functions can also be tested by neuropsychological tests. Bender Gestalt test. It is the most commonly used screening test for organic brain dysfunction. I will show you an image. And number 2, MMSE. Mini mental status examination. It is a bedside screening test for dementia. Less than 24 out of 30 is dementia. I shall show you these two images. First is a Bender-Gestalt test. It is a screening test in which first we give a target fig image to draw and the patient tries to copy. And when he is unable to draw, we say cognitive dysfunction, visuospatial dysfunction. Second is a battery mini mental status examination. It is a bedside screening test for dementia. Because in old age there is cognitive decline. Up to a certain level, cognitive decline in old age is considered normal. Up to what level? 24. Below 24 is considered to be dementia. Below 24 is considered to be dementia. Let me show you the images. This is Bender-Gestalt test. This is the target figure given and this is what the patient has done. It is the most commonly used screening test for organic dysfunction. The patient cannot draw, that's why we say organic dysfunction. Next is your MMSE, mini mental status examination. Total score is 30. It's a bedside screening test for dementia. It is a quantitative test of cognition. So far we were doing a qualitative test of cognition. Orientation present, orientation absent. Now we are going to give orientation marks out of 10. What is the year, season, date, day, month? Where are we? Country, state, town, hospital, floor. So when we are giving marks, we are quantifying the cognitive deficit. Why are we quantifying? Because I just mentioned in old age, some degree of cognitive decline is considered normal. When it is below 24, we call it as dementia. It has 5 domains: orientation, registration, attention and calculation, recall and language. Orientation 10 marks, language 9 marks, attention 5 marks, recall 3 marks, registration 3 marks. Total 30. 10, 3, 5, 3, 9. Total 30. If it is below 24, it is dementia. The questions asked on this are: it is a bedside screening test for dementia, not a diagnostic test. Number 2, total score 30. Number 3, cutoff score 24. Number 4, number of domains tested 5. Highest score given to orientation. Then in general psychiatry, after MMSE comes projective personality test. There are 2 types of personality test. One is thematic apperception test, projective personality test. Projective personality test. One is TAT, thematic apperception test, and one is Rorschach ink blot test. Rorschach ink blot test. There are 2 types of test. Rorschach ink blot, where there are symmetrical ink blots are shown, as you can see. These are symmetrical ink blots. And one is thematic apperception test, TAT. In our exam, the identification came. Projective personality, Rorschach and TAT. Rorschach and TAT. Rorschach ink blot test, thematic A perception test. These are the only image-based questions we have in chapter number 1. Rorschach ink blot test and thematic A perception. How will you identify Rorschach? These images are bilaterally symmetrical. And how do I identify TAT? All these are human faces. This is projective personality test. Just before we are about to conclude chapter number 1, I would like to tell you I started chapter number 1 with how to make a diagnosis. We discussed history, we discussed examination, we discussed investigation, and we reached a diagnosis. Investigation, we have test. Tests in psychiatry are only two. One is neuropsychological test, BGT, MMSE, and second is projective personality test, which I had just shown you images of. Rorschach and TAT. Please make sure you write in your notes, refer images. Whatever images I am showing you here, I shall be uploading them in the file section of this course, where you can refer them after this for revision. So we are about to complete chapter number 1. Just one last thing. General psychiatry is getting concluded. I will introduce clinical psychiatry in this chapter itself, so that in the next video I can go ahead with chapter number 2. Clinical psychiatry means disorders in psychiatry and disorders in psychiatry have been traditionally classified into psychosis and neurosis. Not from today, but from the time psychiatry has come up as a subject, there have been two types of patient, one who come and other who are brought. Those who come are called neurosis and those who are brought are called psychosis. You might have heard a patient being forcibly brought to the psychiatrist. That patient is psychosis. You might have heard a patient coming willfully to a psychiatrist. That patient is called neurosis. Okay, so insight means awareness. If the patient is aware about his illness, it is neurosis. Not aware, psychosis. But this concept is old. Why it is old? Because nowadays we don't use this. Because nowadays we consider these disorders to be convertible. When a psychosis improves, it becomes neurosis. When a neurosis deteriorates, it becomes psychosis. For example, first time schizophrenia is to be brought to me. Nowadays, schizophrenia itself comes walking in my OPD, sir, please give me medicine, otherwise I will be as mad as earlier. So insight is coming. Psychosis, neurosis were previously like this. Psychosis absent inside, neurosis present inside. Now they are like this. A psychosis may gain insight, a neurosis may lose insight. Because nowadays we don't use insight absent and present, we rather use grades of insight. Grade 1 means complete denial of the illness. I have no illness at all. Grade 2 means not sure if I have an illness. Grade 3 Yes, I have an illness which is caused by external factor. Somebody has done magic on me. That's why I have an illness, medical or magical. Grade 4 is when he understands that yes, I have a psychiatric illness. And grade 5, the highest level of insight, where he understands that he has a psychiatric illness for which he needs to take treatment regularly. Very few patients reach grade 5 insight. Grade 5 insight, that's why it is called emotional insight. Highest level of insight. Most of the patients are at grade 4, intellectual insight. They understand they have illness, but they don't understand the value of the treatment. So previously we used to say insight absent present. Nowadays we don't say insight absent present, we say insight grades. AIIMS exam. Grade 1 is complete denial. I don't have any illness. Grade 2 is yes, no. Grade 3 is yes, external factors like medical or magical. Grade 4 is yes, psychiatric illness. And grade 5 is true emotional insight. So insight present absent is no longer a criteria. So the real criteria nowadays is reality contact. Reality contact is lost in psychosis and present in neurosis. What do you mean by reality contact? Contact with reality. That means delusion or hallucination present. If they are present, it is psychosis. If they are absent, it is neurosis. If they are present, it is psychosis. If they are absent, it is neurosis. Loss of reality contact is a marker of psychosis. Loss of insight is not considered as a marker of psychosis because insight can be present also. Got it? This is the background of clinical psychiatry and this sets a foundation of chapter number 2. Catch me up with the video of chapter number 2. Make sure to see the MCQ video of chapter number 1. After every chapter, I am also recording a separate video of chapter wise MCQ discussion of important MCQs. Please see that video also. Chapter 1, its MCQ videos. Chapter 2, its MCQ videos. Then you go ahead with chapter number 2. Alright, catch me up with chapter number 2 video after you see chapter 1 MCQ video. Thank you.